All right, welcome back to part 2 of 3 on assessment in pediatrics. So let's look at the evaluation steps, okay? The first is a referral, then an occupational profile, select the assessment methods, administer the evaluations or the assessments, score and interpret the evaluation process, and write a summary, report, and goals, and then share the results. We're going to pull that apart. So the first step is the referral. There's a variety of places a referral can come from and a variety of protocols. Referral forms can help identify the areas to be assessed. So when we get a referral, it's typically from somebody who's noticed a problem, right? Number 2 is the occupational profile. So we will interview parents or caregivers or other professionals, in some cases the child themselves, and we'll review the chart and previous assessments, including demographic info, past results and info, and interventions that are currently in use or have been used in the past. So it's all this intake. Then we select the assessment methods. There's a lot of different types of evaluation methods and assessments. They're based on the occupational profile and selecting frames of reference. So going back to our theory lecture, right? So we choose the methods, standardized, ecological assessments where the child is in an environment and we're watching, skilled observations. It could be of particular skills or it could be in a more general way like a play observation. Interviews, inventories and scale, so those would be questionnaires that would help us identify issues. And then the decision of a team or an individual assessment, as I said a little earlier. Then we actually do the assessments. So we administer tests according to specific instructions when they're standardized. Usually there's a script, right? We provide and administer questionnaires to caregivers and other professionals. So we might help them if they need it. If they're not completing the questionnaire and that makes it invalid, we would help them finish it. And so there's a variety of ways to do that. We also use skilled observations to augment the other information we've gathered. It requires a good understanding of typical development and what typically should be seen in a child of a particular age and stage of development. We also want to look at cultural, environmental, and other factors. Then we score and interpret the evaluation. So scoring standardized tests requires standardized procedures, and there's typically guides or handbooks to do that. We also want to ensure that sufficient data gathering has happened. And sometimes, I will do an evaluation, look at the results and say, you know what, I'm missing this one thing. And I'll actually go back and do some more assessment of the child or talk to their caregivers to get that additional information. So it's a little bit of an iterative process. We then analyze and synthesize the findings and the patterns of findings. And what that means is that it's not enough really for a quality pediatric OT to say they scored in the 37th percentile on X, Y, and Z, and they scored at this age range on this thing. And what we want to do for the family and the team is we want to interpret our results. So they scored in the 37th percentile. Well, what does that mean, right? Not only what does it mean in standardized assessment language, but also what does it mean functionally? I cannot overestimate the importance of actually synthesizing and interpreting what we find so that we can make sense of it in terms of a child's occupational engagement. 6 is summary and report. Excuse me. And the summary takes all that information and puts it together, right, into a nice little package. And then the report has all the information and the scores. The findings, again, what does this mean? Why does it matter? That's really key. We summarize the referral, the strengths, the needs, and the findings, and then we make recommendations and provide goals. Now, the bullet point says as appropriate, right? So what this is referring to is that sometimes we don't feel like we've gotten quite enough information to formulate goals. And so we, depending on who who you're working for, you might see the child once or twice and then formulate your goals, or you might meet with other folks who are involved with that child to collaborate on goals and then set your goals. So there's a little bit of wiggle room sometimes, and it can be more effective to set goals a little bit later in some instances. Finally, step 7, we share our findings with the family and caregivers, the individualized educational plan team, the child as appropriate. It may be verbal or written. Typically, there's a report and then we talk about it. It may be formal or informal. So in my private practice, sometimes I'll just have a phone call with a family and I'll say, I did some evaluation, I completed this assessment, and here's what I found. Do you want me to write it up? Do you need it for any purpose? I'm going to use it to inform intervention, and here's how, right? So sometimes you need it to be formal and other times not so much. And then, really importantly, we want to allow for questions and follow-up. Okay, so we're going to go down the road of a little bit of standardized assessment and also clinical observations, what those mean. You probably recognize or at least have heard of these before, and some of you probably really into it, others of you not so much. But it's important to understand the different kinds of standardized assessments because they do different things. They serve different purposes. The first kind is norm referenced. So what that means is that the child's performance is compared to a sample of same age peers. And the scores indicate the child's performance relative to that sample. Optimally, the sample is large and the kids are similar to the demographics of the child that we're evaluating. And we say 85% of 5-year-olds can draw a triangle, right? And our client is 5 years old and cannot draw a triangle. That would be an example of a norm referenced item, right? And a norm referenced assessment is a collection of all of these items, but it would be a sample of comparing a child to a large group of same age peers to see what can the 5-year-old do, right? The other kind of standardized assessment is criterion referenced. This, rather than comparing the child's performance to a sample of peers, they compare the child's performance to a specific definition of skill mastery. And it's reflected in the developmental milestones. So for example, if we take the draw a triangle, right? Rather than saying the 85%, is that what I said? 85, and I'm making this up, okay, so don't write it down. 85% of kids can draw a triangle by the time they're 5 years old. What we would say is, okay, can the child draw a triangle? A triangle involves 3 relatively equal length sides that come to sharp points. There's not more than a 1/4 inch overlap or gap between any of those sides, and the size is similar to a sample that has been provided for the child to draw from, right? So what I'm doing is I'm describing the criteria for what it means to draw a triangle. And so in a criterion reference test, there will be very specific criteria about what it means to be successful on an item in the test. Bring questions to class if you have them about these concepts, because they can be a little tricky to start with. There's advantages and disadvantages of standardized tests. We like them because they're objective and they're consistent. If 9 out of 10 dentists recommend a certain kind of toothpaste, we're really happy about that. And we're really happy to use that toothpaste, right? Because it's numbers, it's consistent, it's objective, we know what we're getting, right? The disadvantages of standardized assessments are that they may use contrived situations, right? So what if all of those what if all of those people that the 9 out of 10 dentists were working on were all in dental school? Well, that would pretty much skew that sample, right? It also lacks flexibility. I'm going to move away from my dentist analogy. When we give a standardized test, we have to read it in a certain way. We have certain scripts that we need to use. We have to score it in a certain way. We have certain scripts that we need to use for that. And it doesn't allow for the child who doesn't fit into those parameters, right? So the child that is nervous, the child that is nonverbal, the child who doesn't warm to strangers, the child who doesn't understand verbal instructions very well, but if shown, can do more than they can do when directed, right? So there's a lot of reasons why a kid could not successfully take a test, and a standardized test doesn't have the flexibility to accommodate for that. It also misses qualitative information. For example, the attempts for a child to compensate for a lack of a skill. So I have in mind a particular client who had very poor balance and had developmental coordination disorder, but he could lock his hips and knees and stand on one leg, right? So his score on a standardized test was in the average range for static balance. However, the only way he could maintain it was to make his entire body really rigid and lock his joints. Not good for his joints, also not very functional when we think about the skill of balance. The test may also not be culturally relevant, and one example of this is I, for many years, worked with City College of San Francisco. They have a number of child care centers and preschools, and very culturally diverse. I think there was at one point 19 different languages spoken and kids from probably about 28 different countries, right? And we gave pre-kindergarten screens to these kids. On the screen, there was an item that was about buttoning a little button strip about this long. It's an item from the Peabody Developmental Motor Scales. And it shows some visual perception. It also shows some fine motor coordination, right? And bilateral fine motor coordination. Well, many of these kids who did great on all the other items could not button the buttons or unbutton the buttons. When we looked into this, what we found was that these kids they weren't exposed to buttons. So it was nothing about the skill of buttoning that they didn't have, but that a button was not culturally relevant to their background, to what clothing was worn. Socioeconomic status figures in there because kids that don't have a lot of money tend to have clothing that doesn't have buttons because buttons can fall off and get lost, and then you don't look as put together if you don't have all your buttons done. So there was a variety of reasons why they could not button, but none of them had anything to do with the motor skill of buttoning. So just an example. Okay, so I'm saying so a lot. In addition to standardized assessments, we also do clinical observations. They're used to augment standardized assessment. They provide a context, and they require a great understanding of typical development and what we can expect to see in a child's behavior. The qualitative approach of watching a child adds depth and context to the evaluation. So it's a very important piece. Sometimes while I'm doing a standardized assessment, say it's a paper and pencil task, I'll watch and get qualitative information as well about what a child can do and can't do, and then how they do it. Is their grip super tight, right? So nowhere on the standardized fine motor test is the information that if they have impaired proprioception, they don't get full points, right? But if I see them with a death grip on their pencil, I know that I might want to check out proprioception. And so that's an example of a clinical observation. All right, that's the end of part 2. Coming up, part 3, and we will be through with our assessment lecture and video. All right, stay tuned.